In continuation of our head-to-toe assessment, today's video will be all about segment 2. And to start with our segment 2 assessment, we are going to inspect the patient's neck.
We should ask the patient to lower her gown. The patient's neck should hold the head erect and midline.
If we see any problems in the jaw angle area, we are going to palpate it to check for pituitary gland problems. Now, we are going to assess the active range of motion of the patient. Let the patient touch her chin to her chest. Then, turn her head to the right and left. Then, let her head toward her left and right shoulder. And lastly, tilt her head backward. Now, we are going to assess the spinal accessory nerve of the patient.
We should instruct the patient to sit up straight and put her shoulders to her back. And we are going to apply resistance to the patient's shoulder as she shrugged them.
Then we are going to assess the patient's lymph nodes in her neck.
As we palpate the lymph nodes of the patient, we must start with this sequence: preauricular, posterior, occipital, submental, submandibular, tonsillar, superficial cervical, deep cervical chain, posterior cervical, and supraclavicular lymph node. We must note the size, shape, consistency, mobility, and tenderness of the nodes.
Now we are going to inspect the jugular veins using tangential lighting of the patient. We are going to let the patient in a supine position and her head elevated to 30 degrees and turn away. Ma'am, turn away. Her head away from us, and we are going to internal the jugular vein distension that is may be visible.
Okay. Now we are going to observe the jugular vein pulsations. They should undulate softly and may decrease with inspiration.
Then we are going to let the patient sit up and we are going to identify her trachea.
By locating the sternal notch and sliding our fingers to each side of it. The trachea should be midline and symmetrical. Then, by standing in front of the patient, we are going to use the fingers of our left hand to push the thyroid gland to the right, and curve the fingers of our right hand between the trachea and sternocleidomastoid muscles. Then we are going to instruct the patient to extend her neck and swallow.
The next thing we are going to do is to palpate the thyroid gland at the back.
Then we are going to place the fingers of our both hands to the patient's neck. And we are going to palpate both the lobes and the isthmus. Next, we are going to instruct the patient to sip and swallow during the exam. And note the size, shape, and consistency of the thyroid.
If the thyroid is enlarged, we are going to auscultate the Bruix.
And make sure that we are going to use the bell of our stethoscope.
Now we are going to observe the patient's carotid arteries and palpate each using our index and middle finger.
Remember to palpate one carotid artery at a time, otherwise, we could block blood flow to the brain.
Now we are going to listen for the carotid arteries of the patient using the bell of our stethoscope.
And instruct the patient to take a deep breath and hold it as we listen to the carotid artery.
In continuation of our segment 2 head-to-toe assessment return demonstration, today's video will be all about the thorax, anterior and posterior respiratory system of the patient. To begin the assessment, we are going to observe the respirations of the patient and ask her to breathe normally.
Respirations should be regular and symmetrical. The accessory muscles should not be used. The patient should be able to breathe comfortably while sitting with her arms at rest.
After the observation, we are now going to assess the patient's anteroposterior and lateral diameters of the thorax.
And move around slowly to the patient's back. Normally, the lateral diameter is up to twice the anteroposterior diameter. Then, using our finger pads, we are going to palpate the spontaneous processes. They should be evenly spaced and non-tender.
Then, assess the respiratory expansion of the patient.
Then we are going to place our thumbs to the level of T10 or the 10 thoracic vertebra. Then spread our fingers, allowing for small folds of skin between our thumbs. Then ask the patient to take deep, slow breaths. As she does, we are going to watch our thumbs move with respiration. Their movement should be symmetrical.
Next, we'll assess for tactile fermentus.
Using the ball of our hand, we are going to feel for vibrations as the patient repeats the phrase 99. Then we are going to move from trapezius inside the scapula down to the lower and lateral thorax. Then we are going to perform immediate percussion using a systematic pattern so we can compare the two sides. Resonance should be equal over the lungs, and we should hear dullness over the diaphragm.
Now, we are going to assess for diaphragmatic excursion.
The next thing we are going to do is to ask the patient to exhale and then hold her breath. As he hold her breath, we are going to percuss from the scapula down where the sounds changes from resonance to dullness. Then we are going to mark the spot with a pen. Ask the patient to inhale deeply and hold her breath as we percuss farther down to the new area of dullness. Then we are going to mark this spot too. And then we are also going to repeat the process to the other side. And after, we are going to measure the distance between the set of marks on each side. Normally, this distance, which represents diaphragmatic excursions, measures from 3 to 5 cm and is equal on both sides.
The next thing we are going to do is to assess the kidneys.
We are going to use a blunt or fist percussion over the costal vertebral area.
And then, we are going to auscultate the breath sounds.
In auscultating the breath sounds of the patient, we are going to use the diaphragm of the stethoscope. Then instruct our patient to breathe deeply through her mouth. And be sure to listen for at least one complete respiration of each location. Normal breath sounds vary with the area we are listening or assessing. We should able to hear bronchoviscular sounds between the scapulae and the viscular sounds at the apexes down to the bases and laterally. We must listen for abnormal sounds such as crackles and whistling. If we hear one, we are going to ask the patient to cough, then listen again to determine. If you suspect an abnormality, have the patient say 99 as we auscultate these areas.
After assessing the patient's posterior thorax, we are now going to assess the patient's anterior thorax.
Beginning with the bones and muscles. Normally, they appear symmetrical and we should not see accessory muscle use, retractions, or bulges. Also, the patient should not have signs of respiratory difficulty, such as nasal flaring. Then we are going to palpate the thorax with our finger pads, moving from the lung apexes to the bases, wherein we should not find any nodules or tenderness.
Just like what we did in the posterior, we are going to assess the anterior respiratory expansion.
We must place our hands on the patient's chest along the costal margins, with our thumbs pointing towards the xiphoid process, and then instruct the patient to take a few deep breaths. As she does this, watch our hands or thumbs move simultaneously and symmetrically.
Then we'll assess the anterior tactile fremitus.
We're going to instruct the patient repeat the phrase 99 and move from the lungs apexes down to a point below the nipples, comparing sides.
And perform percussion and auscultation over the patient's lung.
Using a systematic approach, we are going to start above the clavicle and percuss in the intercostal space down the chest from side to side. And then auscultate over the patient's lungs with the diaphragm of the stethoscope in the same pattern used in percussion. At each location, we are going to listen for one complete respiration. Normal breath sounds vary with the area we are assessing or auscultating. If we suspect any abnormality, have the patient say 99 several times as we auscultate the areas involved. But since I did not hear any abnormality, I was not able to tell the patient say 99 several times.